All right, here we go.
All right. Well, welcome everybody who's entering the webinar now. My name is Ben Hummel, and I am a CHW ally and a board member at NACHW. I join you today from the state of Maine, where I work at Maine's Public Health Department. I've been a longtime collaborator with CHW networks in our state, and I sit on the Workforce Development Committee at NACHW, and I'll be the moderator for the webinar today. And the webinar we are presenting is Lessons Learned from CHW Training and Apprenticeship Programs. And we have an impressive group of panelists today joining us from 5 different organizations. I want to thank all of them for sharing their time, expertise, and experience with us today. So as part of our agenda on the call today, I'll get us started by providing an introduction about NACHW and the Workforce Development Committee. For the next hour, we'll have 5 groups of panelists provide a high-level overview of their training and apprenticeship programs through a series of presentations. After that, we'll be transitioning to a 10-minute question and answer section. And that will be followed by breakout sessions after that for about 20 minutes, where we'll be looking to move the conversation towards higher level themes around workforce development efforts in our respective states. And then we will come back together after that as a full group to do reporting back on what was discussed in the breakouts, and we will wrap up with an evaluation of the webinar. First, I want to provide a quick overview for NACHW for those of you that might be new to the association. The National Association of Community Health Workers was founded in 2019 after several years of planning and organizing by CHWs and allies from across the country. The vision of the organization is to unite CHWs nationally to support communities in achieving health, equity, and social justice. And this slide also lists the core functions of the organization that we use to advance that overarching mission. As for the Workforce Development Committee, it's one of 5 standing committees chaired by NACHW's board, which also includes CHW and ally members of NACHW. And the mission of the Workforce Committee is to convene both CHWs and other workforce stakeholders and to facilitate the exchange of resources, ideas, and models around education, capacity, and infrastructure building, as well as economic development and sustainability models. One of our goals as a committee is to convene employers around CHW training and professional development, and this webinar is our first attempt to connect with and engage our members that are involved in programs funded by HRSA 22-124. Our goal is to facilitate shared learning and better understanding of what sort of support we might provide to members around training and apprenticeship programs. But to be clear, we are not affiliated or representatives of HRSA, and this is not a technical assistant event for HRSA grantees, but rather a learning opportunity for our members today. Looking now at the learning objectives for the webinar, participants today will discuss the successes, challenges related to building CHW and apprentice models that are funded by HRSA 22-124. We will also look to identify opportunities for authentically partnering with CHWs in the design and implementation of these programs. We'll consider policies and supporting infrastructure that you have or that you need to build the sustainability of CHW employment after training. And we'll also be looking to explore areas for ongoing support that NACHW can provide to members. Promoting authentic engagement with CHWs and allies to champion CHW self-determination and equitable workforce development practices are at the core of NACHW's advocacy priorities. I would encourage you all to go to the policies section of the NACHW webpage where you can read more about NACHW's policy platform, which provides recommendations on how institutions can respect, protect, and partner with CHWs. The webpage also contains past statements that NACHW has released about opportunity and challenges related to federal financing, infrastructure, and capacity building efforts, including NACHW's response about the Notice of Funding Opportunity for the HRSA grant. There are also other resources there as well, like the CHW Resource Center, which is the nation's largest searchable collections of documents on policies around CHWs that also might help inform a work that's going on at the state level to develop training and apprenticeship options. NACHW is also launching the first ever National CHW Awareness Week in the fall. This is a national campaign that will seek to increase awareness of CHW identities, roles, impact, and leadership, and to promote policies that respect and protect and authentically partner with the profession. You can learn more about this event as well on the webpage, which will be listed in the slides, and it includes a recording of a recent webinar about the campaign, and there will also be a toolkit that is coming soon, which offers guidance to those that wish to coordinate events in their state in collaboration with the larger campaign. It's important to acknowledge that NACHW does not currently endorse a set of professional development standards for the profession per se. We defer to states to establish CHW workforce policies in partnership with those working in the profession. NACHW endorses the APHA policy that at least 50% of those involved in workforce decisions should identify as CHWs. NACHW also looks to promote the existing capacity of CHW networks and training programs across the country to provide professional development resources. And our website, you can also find a directory of these CHW networks and training programs as well. I've also listed on this slide a link to a Data for Action series, which presents results from a national survey of over 800 CHWs that NACHW conducted in 2021. And it includes findings related to issues of pay equity and career pathways and barriers. I would encourage participants to also take a look at the infographics as part of that series to provide more context for our higher level discussions today around professional development and sustainability. And finally, I also wanted to provide a quick plug that NACHW is hosting its Unity Conference and annual meeting on August 3rd to the 5th in Austin, Texas. For those of you who are not familiar, this is an interactive event designed for CHW and ally members, where you will have an opportunity to learn about best practices, meet peers, unify our voices, and vote for NACHW's board. So I would encourage you to check out the link that's listed on this slide if you'd like to find more information. And for those of you that cannot make the trip to the conference, there will also be a virtual option, which is free for CHW members and a reduced price for ally members. So I would also encourage people to consider registering for sessions that way as well. So now that we've kind of wrapped up with our introduction, we'll be moving to our panel presentations. I'm going to provide just a quick overview of our panelists today. They will do kind of their introductions a little bit more in depth as part of their presentations. But we have a team from Loma Linda University in California with Pamela Fernandez, Alejandra Morales, Dr. Suzanne Montgomery. We will then have a team from Johns Hopkins University, Kimberly Haley Fair, and Dr. Benajis Skeliestatos. After that, we will have Tara LaMurray from Rhode Island College. We will then have Wade Forehand, or Dr. Wade Forehand from Troy University in Alabama. And finally, we will wrap up with a duo from Purdue University in Indiana, which is Dr. Cody Mullen, as well as Margarita Hart. So I would now like to invite the team from Loma Linda University to begin their presentation, and I'll stop sharing my slides.
Thank you, Ben, for that introduction. Good morning or good afternoon to everyone, depending where you're at. I'll be sharing my screen in a moment. There we go. Well, thank you so much for this opportunity and for this time to come together and learn. That's mainly the purpose of this point or this meeting. So thank you for making a time, everyone, to join and be part of this sharing and learning session. During these brief presentations, we will be sharing highlights of what we found helpful as recipients of the HRSA grant in regards to partnership, development of the training, recruitment and retention, as well as challenges and successes. Just to make sure that we share this presenter disclosure statement, presenters have no financial relationships or commercial interests relevant to this presentation to disclose. And also presenters, we are not HRSA representatives. We are Loma Linda University, who is a HRSA grantee. So our team here today representing Loma Linda University, San Manuel Gateway College. The college is located in San Bernardino County, California. Some of you may know it as the Inland Empire. So we are a faith-based academic medical center that has served underserved local and global communities for more than 100 years. And we strive to transform lives through education, healthcare, and research. And I would like to start with the partnerships. So how have we gone about the partnerships during this HRSA grant? We have identified partners who already employ CHWs or engage CHWs, also those who are interested in CHW integration. And we also look for organizations who have these characteristics, organizations who would like to integrate CHWs into their sites, into their systems. Through this time during HRSA, we have arranged for informational sessions to make sure that all of our partners come together and we ask and answer questions that they may have. Also, we provide organizational readiness trainings. We help organizations to identify the role of CHWs, how they can be integrated into their systems, how best magnify and maximize their roles and skills and lived experience that CHWs and promotores bring into these organizations. Also, through HRSA and through this opportunity, we have set aside administrative financial support included in a budget. We know that organizations also are putting time and effort in providing this collaboration, providing data. So we want to make sure that we can support that. So we have incorporated budget for administrative support. Another point that we recommend and we have seen working very well is visiting the sites and building the rapport. We need to meet in person, understand their needs, talk to the leadership, to the CHWs or the potential CHWs to understand what's the need. We have also used legal service agreements, and these serve us to have clear expectations and make sure that we're delivering the expectations as well. In regards of the training, apprenticeship development, training, what we have based our training and development is on the CHW core competencies, identifying the roles and qualities of CHWs using also the C3 project. We have incorporated and aligned the public health core competencies throughout our training and enhance the CHW engaged strategies and tools that our students and future CHWs and promotores will use and apply in their communities. We do have a component of field practicum that connects everything together, making sure that what they're learning, they're applying, identifying, and connecting to their communities. Throughout the trainings, professional development and workforce development has been key. In regards to apprenticeship, it will depend on whether you are providing in-state trainings or across the region training. So we will recommend that you connect with your state or federal Department of Labor, and this does take time, and you should connect with them right away and build up this system. I will be moving on now into recruitment and partnership and passing on the baton to Alejandra.
Thank you, Pamela. Good morning, everyone. Well, this is the part of that I love, the recruitment and participants. How do we recruit the CHW? So we want to screening the CHW candidates. We want to ask them for a letter of support. We want to know why they want to become CHWs. Why do they have that seed on them? Why would they want to continue educating and getting the course and the training, right? So we also want to know how they are and if they have any needs. So we assess the students' needs. We want to know if they're living far, if they need transportations, because we really believe that those needs, they have to be addressing in order for them to complete successfully the training, the course. So we also have a team, a coordination teams in regard to students enrollment. It's a lot of work back and the offices, enrollments, processes, letters, typing. So we have a whole team coordinating all this paperwork to have in order to start the processes for the course. And last, we do also provide an orientation day. It's a whole day of orientation. So we actually walk them through the platforms that we utilize. In this case is Canvas. We utilize Canvas for the students. So we want them to build these, develop skills for them to use platforms. So we have a whole day of orientation, but all this paperwork, we basically navigate and walk them through all the steps, how it's gonna look like, how they're gonna submit their assignments, how they're gonna submit discussion boards, how they're gonna watch the videos in case there's any video or resource. So we want to make sure they get familiar into it so they don't be like a little bit nervous to get into the course, correct? Next page, please, next slide, thank you. And the orientation for the participants. This is my favorite part of these. How do we do that? So I wanted to really highlight that in the classroom, we do practice popular education. I am a CHW and I become a CHW years ago, but I know that for me to feel safe, a safe environment, a safe place to learn, but also to share is very important to me. So we do practice popular education. It's not that I'm teaching and you're learning, it's a learning together process. We're here to share from expertise, but we allow them to also share from their own expertise as well. Because we know we have so many promotores and CHWs coming with so much experience, we want to enrich and enlarge that classroom. So we also want to create and promote, build individual and group capacity. I know we have so many promotores and CHWs that is so good. We're really good working with community and we have that passion, but maybe typing skills or maybe some type of skills, it's like, you know, getting a little difficulties for us. So we want to build that capacity as well. We do have the team, we have another instructor who actually goes into professional development. She does an amazing job walking with them again, like letting them know that we here for them. So we actually go and do typing skills and some computer skills so they go smoothly in transition to elevate their role as well. And for the team, with the team, we do coordinate. It's a lot of a coordination, a lot of phone calls, a lot of lists. We do a lot of teamwork. So we have to prepare the course. We want to prepare them with time. We want to be ready for them. We do prepare way ahead of time all the courses and what are we gonna say and what do we want them to absorb. Team communication and support is also very important, especially if we know that we're gonna have students that are gonna need special not special, but they're gonna have more accommodations or they need a support. It's something that I think is make us not unique, but make us more, I would say, empathy. We want to, we don't come just to teach. We want them to know better. So we want them to succeed. And a lot we do provide students with spaces here at the campus so they can work independently. Is the case that they don't have laptop or computers. So we do provide a skills lab for them, a lab with computers and other resources, even including like a little food pantry for them. In the case they forgot lunch, so they're there. They have also space to study, a space to learn, and computers that they need. So this is what we do to retain. Last, I would like to mention that having a CHW instructor instructing and working with this group is also very important. It feels like we don't teaching, we're walking. So this is part of the retention or keeping the class to succeed as part of the training in the class. And then I will pass the baton to Ms. Dr. Montgomery.
Thank you, Alejandra. I know that I'm running close with time, so I'm going to go very briefly. Ben, I see your face. I'm going to go very briefly through the challenges and the successes. So getting money is wonderful, and then you sit down and you realize we got money and now we have all these expectations. So HRSA money come with lots of expectations and lots of things that are not necessarily the usual part of CHW training. Working with the federal government is all about accountability. So you have to report what they need to be reported. Unfortunately, while it's been wonderful having the funding and the support of HRSA, it also meant that it was slow coming about what exactly we were required to report. But then when it came to reporting, we had to report it. So we had to be very nimble and prepared and anticipate what needed to be done. We realized that when we have HRSA money, we need to be very good about communication. So we had assumptions initially about what would be done based on the grant. Very quickly learned that our assumptions were not necessarily the right assumptions, so we had to clarify that. We have a wonderful project officer that has become our best friends. We have lots of communication, and because of the communication challenges between us and HRSA, we had to become very intentional among our team. So for instance, the leadership team, we communicate regularly. We always include everybody in the CC so that everybody's informed and is clear about the expectations, about the documentation, about the reporting, about the problem solving, how to address all of those expectations. Deadlines mean deadlines for HRSA. They are not they are not used to delays. So we have to really be very tight to deadlines. And if anything, we have learned that we need to be in touch with our project officer and HRSA leadership to be very clear, verify our understanding, and seek clarification. So it's a lot of opportunity, and we are very excited to have it, but the funding is not necessarily easy funding. And there's lots of work to implement it, which is understandable because it's actually an initiative that is closely watched by both the CHW community and the professional, the Congress, who was very divided in funding this opportunity. So thank you for giving us an opportunity to talk.
Yeah, thank you so much to the team from Loma Linda University. I know it's hard to fit an overview into a short period of time, but you all did a great job. And next, we'll move it over to the folks from Johns Hopkins University, Kimberly Haley-Fail and Dr. Panagis Galiastatos.
As my colleague Kimberly gets the slides ready for the next, we have 92 slides to get through in 10 minutes, so I'm teasing. It'll be fine.
That sounds like me.
No worries, but Kimberly, whenever you're ready, kick things off.
Okay. Hi, everyone. Is it full screened?
It is now, yes.
Yay, yes. Thank you. Thank you all so much for having us this morning. So again, my name is Kimberly Haley-Fair, and I'm joined by Dr. Galiastatos. And we are representing Johns Hopkins University, and our CHW grant is called HEAL, and it stands for Health Educators, Advocates, and Leaders. And our disclosure statement is that we are also not representatives of HRSA. We work for JHU, but we're just here to discuss our project and give you a little bit more information about it. So the goal of our project is to advance health equity as well and reduce health disparities through our well-trained CHWs in our vulnerable populations. So I'm going to pass it over to Dr. G.
Yeah, thank you so much, Kimberly. And, you know, the HEAL initiative, it came together for the purpose of submitting for, oh, go ahead to the next slide.
Okay.
It came together really for the purpose of the HRSA grant, but in recognition, and this is oftentimes what a good grant should do, say, hey, you have a variety of things that work well, pull them together to make a bigger impact. That's what we strive to do, right? As opposed to being true academics and just doing too much with too little. So where we've kind of pulled a lot of our collaborative efforts, one is through the healthcare system, and another through an entity that we've had around for the last 10 plus years called Medicine for the Greater Good, which teaches healthcare systems how to do effective community engagement for the goals of either population health strategies or community health, or a combination of the two. Through our last decade of MGG, we've established well over 100 community partners. Majority of them are faith-based organizations. Another portion of them are scholastic entities, schools, et cetera, and then housing units. But we have these collaborative organizations always willing to collaborate with us, and vice versa, us willing to collaborate with them whenever certain community health needs arise. And when I say health needs, I don't mean they want us to tackle their diabetes. I don't mean they want us to tackle their hypertension. They may want us to tackle, hey, we're suffering from low unemployment in this community. Can you assist us with that? They may want to ask, hey, can you assist us with having our parks updated in regards to having a safe space to be present and so forth. So the last 10 plus years with MGG, we really have become a bidirectional unit in order to advocate for a lot of things that we do with them. And the healthcare system's role in it is because with MGG, we've integrated it into the education of resident physicians and established faculty, right? So they can understand the sophisticated science behind a true effective community engagement, which isn't just going out and say pulling off a health fair. No, right? Your community has plenty of tchotchkes. It's going out and actually truly collaborating with them, going out and truly being seen as a partner with them who happens to be a doctor or a nurse or an NP or health administrator. So the last 10 plus years has really taken into account these two entities that we have established well. Go ahead to the next slide, Kimberly. And the impact of that was really felt during our pandemic, right? Where we pulled through the fabric of trust with these community partners saying, hey, the pandemic is here. Your doctors or nurses, what you're hearing, it's bogus. We are not your front line. We are a last line of defense. Those who can save lives are you all, helping people not catch COVID and helping people get the vaccine out. And this CBS Sunday Morning story really captured that succinctly, really understanding kind of the gravity of what it means to have true medical community partnerships where each individual can really heighten its strength. And the reason why I'm building this up, go ahead to the next slide, is because these partnerships, when you have great liaisons that are active there, that serve both the health system and the community, they're the ones who end up delivering these kind of healthcare resources that benefit the communities themselves, in addition to benefiting the health systems in regards to a mutual understanding. And so that, medical religious partnership that you saw actually became what the Baltimore City Department of Health and the mayor's office actually led with. And that's myself with my long pandemic hair. You can't see the beard under the mask, but nonetheless, that's the strategies they used. And the reason why I wanted to bring this forward is because many of you discussing kind of the collaborations that you'll do, where you pull the community health workers and so forth, and the goals you want them to strive for. One of the challenges that I will pose is, as I'm hoping many have been doing the work already, right? These kind of reliances on grants or certain fundings to begin. The challenge is all of this great work that we are doing now with regards to the HEAL initiative is building off of 10 plus years of establishing ourselves within the Mid-Atlantic region of a trusted entity because we've collaborated with them before. Right, we've worked with them before. So when we train our CHWs with additional training through the HEAL grant, they're being plugged back into communities or within health systems that they have become comfortable with, either from a trust or they're being pulled from places that they know of, right? That bidirectionality is there and alive. And I really make this a case because the allowance of doing community engagement work has to be built off of already an established sense of rapport and trust that should be rooted in something meaningful and something purposeful, right? Executing this work that we've done and the future work that we're going to be doing, that you'll hear from my colleague Kimberly, has come from that. And for many of you wanting to know the secret recipe to this, it's persistence, consistency, and presence. That's it. That's what communities often need of us, and establishing some level of homophily in order to really kick things off, of making people recognize we're in this together. So Kimberly, I think you're next, or am I still next? Oh my gosh, I can't recall the slides.
Yes, I'm next. Oh, Thank you. Thank you
over
so
to you,
much.
my friend.
So along those lines of community buy-in, we have been able to focus very heavily with this grant on the community aspect of community health worker. So we've been able to utilize resources that we already may have in-house. So using different physicians, clinicians, resources that we have that are free at the hospital. So we received a donation from 3M of a little over 42,000 face masks. So we've been able to use our CHWs that come and pick up face masks and distribute them to their community. And we're able to hear questions back. Maybe there are some questions about vaccine hesitancy. Maybe there are questions around COVID preparedness and other health issues that may be concerning their community. So we're using our CHWs as these sort of liaisons between the resources that we have and the resources or questions that their community may also have. So this in turn adds to our positive word of mouth. So from this word of mouth and building trust, we're able to recruit participants for our grant in the old school way, right? So they're just saying, we've seen you guys out and about. We know what you're about. We trust you. We see the positive effects. I would like to contribute to that. How can I apply to be a CHW? So we've gotten lots of applications about that. And we're using these opportunities to discuss all of our programs, all of our grants, which we'll talk a little bit about our trainings, but just what's free, what's happening, all of our events to keep people involved. And this aligns with us decreasing the barriers to our program application and also retention, because we are focused on marketing and reaching out to these vulnerable populations, our priority populations. We know that there may be concerns around financial support. So through this grant, we've been able to provide stipends, cover tuition, cover childcare costs, health insurance costs, anything that may be prohibiting someone from finishing the program. And as well as providing continuing education resources. So some people may apply to the CHW program and they haven't done schooling prior to that, as far as like a training program. And so they may feel overwhelmed about going into the community and using what they've learned. So we're able to use our professional development courses, and we provide weekly Zoom calls and emails to keep people up to date on what is happening. So we're not just throwing our CHWs out into the community, we're making sure that they have this supportive network of our health system. And we're also giving them culturally appropriate resources. So we work a lot with the faith-based communities. We work a lot with our Spanish-speaking populations here in Baltimore. And we're making sure that the resources and material are translated and representative. So people can complete their program and they feel like they have information that is reflective of the communities that they're going out to reach out to. And I'll go to the next slide, Dr. G.
Thank you so much, Kimberly. And as we talk about like the training and the apprenticeship, you know, the training for us is going to be important in an effort to give this community health workers two insights, right? We recognize what we're going to pull from them is to some extent their own empathy, their own understandings of the communities that they'll serve, they'll give back to. And a lot of it comes from their own personal experiences, and that's going to be powerful. We want to promote that. That in of itself is going to allow them to establish that sense of connectivity, social cohesion that's going to make them able to promote the health and wellness that they want in their respective communities, as well as a bidirectional liaison, as Kimberly mentioned, towards the health system. So our CHW curriculum goes over certain aspects about the health system, and at the same time takes into account conversations and training around cultural humility and implicit bias as well. We want them to retain certain levels of skills that can assure there isn't any confounders towards potentially more diverse communities that we're giving them the ability to work with. Right, this is key. Right, they may be pulled, like for instance, in Baltimore, you may be pulled from working with a neighborhood of Ponca Street, but suddenly when you're going to be engaging with the entire Highlandtown section, you need to be aware of the diversity that comes with that territory, right, within that constraint of that actual neighborhoods and so forth. So we want them to have those social skills that is analogous towards really the entire health system, right? I, as a physician, have gone through my own training of cultural humility and implicit bias, and we want to give that same kind of professionalism towards our community health workers that we train. And then it's our lay health educator program. This is what we've done for the last 10 plus years with Medicine for the Greater Good. This adjunct that's being utilized for them, as Kimberly mentioned, is kind of a continuing education tool. What the lay health educator program is designed to do is give community health workers, and prior to them, just community members themselves, really a behind the scenes understanding of how a health system thinks. How do we prioritize the management of patients? And it's, for some of them, it's very eye-opening, right, of how we govern population health strategies and so forth. But we actually see it as an ability to try to understand what these stakeholders are interested in, and then how do we utilize our ability to kind of meet in the middle, right, through good community engagement that community health workers will implement. That's the strategy here. Well, if healthcare systems prioritize that and we prioritize this, where's the Venn diagram overlap? And one of the big key things we teach through the lay health educator program is advocacy, right? We make it clear that politics is health, that a lot of the constraints and situations that we face aren't there just by random chance. Those oftentimes are kind of intentional. And to be able to undo that, what we've asked a lot of community health workers to take on as they see fit, as they can apply it to their own life, and recognizing that they'll be doing it in collaboration with us, because we train our own physicians through Medicine for the Greater Good to do the same thing. How do you get to your local city hall to advocate for certain local legislation that can make key differences now, right? That can take the good actions of good people to make sure those good moments and times aren't lost and truly translate into significant movements. That's what we want. At some point in time, we love the reactions that we're doing, but we need to make things easier to do good health, to promote good health, and to get good health out into the communities that need them. So our CHW curriculum, in addition to training them with the training that's analogous to community health workers, we do add additional training overall for them to kind of be able to utilize their talents in a way that serves the community wholeheartedly, and then additional skill levels that we believe that gives them the ability to be really substantial liaisons, employ this kind of bidirectionality between health systems and the communities and social organizations that they'll engage with and work with, ultimately, I mean, for the big goal of achieving health equity. So Kimberly, is this me or you? Since you're not coming on mute, I will, I'll imagine this is me. All right, so in regards to the recruitment successes, again, a lot of what I love is that we've been able to reach to a lot of the communities that oftentimes are seen by health systems as the unreachable. Look, I'm a son of immigrants. I grew up in a heavy immigrant part of Baltimore. I didn't speak English until I was 5, and I always make the joke that the first time Johns Hopkins rejected me was at birth, because my mom showed up to the hospital, couldn't speak English, she left. And we've had a few CHWs come from that community itself that I'm so proud of, right? Because again, it's kind of an untouchable community where you stay siloed unless you really need something. And so one of the things that we have done over the last 10 years of establishing so much of this community partnership and collaboration is when we've gotten the grant and we put out the flag like, hey, we're happy to take people on. People came, people are coming. And that to me is one of the most important things that we can do in regards to making sure that we have a representation of what it means for the local city of Baltimore City and for the state of Maryland as well. The other part that we're very mindful of is, for a lot of people becoming community health workers, this isn't going to be a permanent position. For others, it may be. For others, it's not. For others, we're hoping this is going to be a good stepping stone into something else, and something else. What we all do in life, right? When we get hired on, we're hoping something bigger comes along the lines where you keep building up to more successful entities. And so we were mindful of that. And some of our early health educator program training will take that into consideration, right? Have you leveraged the skills you learned as a community health worker into employment for other positions, into other positions, and so forth? And many of our own community health workers, these are going to be amazing leaders, because they already are, but leaders for even more profound situations and systems where they can have a bigger reach. And we want to prepare them for that, right? We're excited with these kind of micro medical revolutions, because if we can get these individuals, as well as ourselves and everyone here, into key positions to make true changes to the healthcare system, to be seen as a public trust, we're gonna be very successful. All right, our biggest barriers, I would say, is probably something you're all feeling, is how do you align and make sure that our goals with community health workers and the social networks that they serve and are responsible to, how do we make sure that they align with the health system's goals and its own population health strategies? Because there can be massive disconnects to this, and ones that are seen as insensitive while we're trying to accomplish others. I can tell you the big way to overcome that is making sure that you have representatives in all the population health meetings that exists, or administrative meetings that are out there. Because for instance, as of today, Kimberly, we got these emails that we were able to leverage hiring of new community health workers for our hospital, something they haven't done in the last 3 years. But a lot of it comes because we're present in those conversations to really promote the good work that community health workers can do, right? We want them to be seen as an asset and have a seat at the table, but you can only do that if you're at the table as well. So that's a big barrier, and one that I recognize kind of has its own responsibilities in of itself, but one that we're trying to continuously change and impact. So with that said, shoot. All right, someone yanked me off the stage. Kimberly, are we done? Good.
Yes, we
Fantastic.
are. Thank you all.
Perfect.
Thank you very much to the team from Johns Hopkins University. We will keep it moving here. So the next person we'll have present is Tara Lamoureux from Rhode Island College. Oh, and Tara, I think you're still on mute. If you could, thanks.
And I was. Hello, everyone. So nice to be here. My name is Tara Lamar, and I am representative of the entire team at the Institute for Education and Healthcare at Rhode Island College. We also partner in-house the Community Health Worker Association of RI right here on campus. So I am here today to represent an entire team that has been put together to work on this HRSA grant and develop our community health worker training and apprenticeship program. I'm going to try to be as brief as possible. Most of you are familiar with a lot of the grant overview. HRSA's goal is 13,000 new community health workers in the workforce. Our first goal was to newly train 170 CHWs. We've been training a core curriculum now since 2009. That was when the Community Health Worker Association of Rhode Island was established. So we've had this curriculum for a while. Our intention is that as students come out of their first core training, they are given a $4,000 stipend. Those are disbursed at completion of that first training. Our second goal is to upskill 55 of current CHWs that are employed within the state and take them through the apprenticeship program. Our last deliverable is newly trained, upskilled CHWs, all placed into apprenticeships. So our apprenticeship model was probably one of the biggest challenges that we faced. Initially, we worked off of a standard that was already developed and approved by the Apprenticeship Board of RI. That was initially developed by an organization called the Rhode Island Parent Information Network. What we realized shortly after going through that model and comparing it to what our objectives were within this HRSA grant and our deliverables, which tend to be very narrow, is that those standards did not really correlate to where we were trying to go with our objectives. So that immediately sent us back to the drawing board with Apprenticeship RI and the Apprenticeship Board of Rhode Island, who reports to the federal board. So with that challenge, what we did is we took the standards that RIPEN had already developed And a lot of that framework was somewhat niche considering the population they serve is parents and families that support kids with special needs. So this grant specifically was focused a lot more on public health. And we had already developed several public health oriented curriculum that we were distributing to CHWs. So we decided to build that into the apprenticeship model and into this grant. So here you can see some of our mandatory education and trainings that are included within our training. We have to get to at least 144 hours. Our core training covers 72 of those hours. To the right and the top, you can see all of our other trainings that are more public health oriented that we built into this grant, and we built into all the competencies that are related to that apprenticeship. In addition to that, we've also seen that CHWs are serving a variety of different vulnerable populations, and so many of their titles are all encompassing like CHWs, but they're taking on strange job roles. And a lot of that has to do with the population they serve. So in addition to the education that we proposed within our grant, we also added additional education, which are some of these specialty trainings that we see listed here. We're also noticing as we continue to communicate with employer partners that there are additional needs within our communities. And those biggest needs are definitely behavioral health, which we already have in our wheelhouse. And also domestic and interpersonal violence is very big in the communities, especially since COVID and the pandemic. So we are presently on the fly working to put together a curriculum that is educating CHWs on how to handle interpersonal and domestic violence. As of right now, we have established 22 employer partners. We are working with federally qualified health centers, CAP agencies, our own health equity zones. Many mental and behavioral health centers really feel the need for CHWs and think that CHWs would be a great support system for them, especially for their social workers. This is another area where we've started to see the lines really blur between education, competencies, and titles. Just because someone is a social worker liaison, like what is the definition of that? In truth, just like a peer recovery specialist and oftentimes peer educators, they all fall under this bigger umbrella of community health workers. So we've been doing a lot of digging within these organizations to figure out who is it that is our main goal to educate, who really makes the best candidate for this role, and also how can we partner with those organizations to make sure that the trainees coming out of our training that are looking for job placement and are serious about their role within the communities have the opportunities that are best suited for them. Another really vital relationship for us has been the one we've established with Apprenticeship RI. They have been absolutely vital in creating the educational and on-the-job learning standards that I've discussed so far. Actually, our apprenticeship just got approved yesterday, so it was a very exciting moment for all of us because we've all worked very, very hard on that. And one of our next challenges is continued recruitment. So our next move is we all feel very passionately about the care of older adults, serving other older adults in the community. Oftentimes we're seeing that we're placing our CHWs in hospital systems or FQHCs, a lot are in housing services and housing authorities. But I think there's a big gap in some of our just community spaces, such as senior centers, libraries, and school systems, where community health workers could be an amazing addition to some of the supports that are needed there. So far, most of our recruitment has been done through the Community Health Worker Association of Rhode Island. Like I said, we were established in 2009, so we have a very vast network throughout the community. We were lucky enough to have a CDC grant that was funding a lot of our CHW training in prior years. So we were able to kind of hit the ground running as soon as this HRSA grant was funded. So we've been through 3 cohorts of core training. We have 51 students that have completed. Presently, 32 are in training, and all of those 32 will be placed in apprenticeships. Right now, I would say one of the biggest challenges we're finding is tracking the apprenticeship applications and agreements. It sometimes feels like it's herding cats and they're coming from so many different directions. And with the large stipends that are attached to this project, there's a lot of interest. And we're also seeing a lot of interest from our employee and community partners. So on one hand, we're growing both our employer partners and the job market and trying to connect those in a way where we can establish like a set wage. It hasn't been easy, and that's another challenge that I can share with you later. So how our stipends and disbursements are functioning right now. They're meant to provide financial support to the CHW trainees, reducing any barriers to enrollment and also keeping them retained within the program. The first $4,000, as I mentioned, is dispersed at the completion of their 72-hour core competency. And then the second stipend is $5,000, and that's made in 2 disbursements in the middle when they finish their mandatory trainings and at the end of them actually finishing their apprenticeship hours. Here you can see an example of our wage schedule. I want to say this is probably one of the most challenging things we have dealt with to date. We work with large health systems, and we also work with very small community-based practices. So trying to get everyone to discuss this in an employer meeting in an open forum was like pulling teeth. Eventually, we just surveyed all the employer partners, and we tried to come along with a range that seemed like it fit, because they are forced into a pay bump at the year end of that apprenticeship. So we started at 18, which is about base entry level here in our state. And we're hoping to get everyone at least 20, but we do have some of those larger health systems that are already paying above that now. Some of the successes that I think we've definitely had and are celebrating right now are developing our own apprenticeship standards that reflect the needs of the grant and also of our communities. Recognizing new opportunities to develop and collaborate on the new curriculums that we're seeing that are necessary. We're also always in the midst of developing new relationships with new employer partners that are finally beginning to see the value in CHWs and want to advocate for them rather than them always having to advocate for themselves. As I've mentioned, defining the actual roles that CHWs are taking on and what qualifies and doesn't qualify in this space has been a little bit difficult. Also, I would say, being that we are requiring so much training of our students and new CHWs, it has been difficult to put together a training calendar, and also making sure that we have a viable schedule for new CHWs coming into the apprenticeship and into the program. And with that being said, I think we're all really excited to see it move forward. There's a lot of hard work going into it and a lot of learning curves that are being mitigated as we work. So I'm happy to have presented and introduce you all to us. Thank you.
Awesome. Thank you so much, Tara, for presenting. Now we will keep things moving here and move it over to Dr. Wade Forehand from Troy University in Alabama.
Definitely. Thanks, Ben. Can you guys see the presentation?
Yes, we can. Yep.
All right, perfect. Well, good afternoon, everyone. Greetings from the great state of Alabama. Our grant effort we titled Troy Health, stands for Training, Resources, and Outreach for Yearly Health. Obviously, I have no conflicts or financial interest to declare. As my colleagues, we are funded by HRSA, but I'm not a representative of HRSA for this effort. And this is just for general knowledge, a shot of our beautiful quad on campus. So just a little bit of background. We received funding and notification in September of 22. We requested $3 million and were funded the full amount. The main goals for our grant effort included expanding the public health workforce by the addition of CHWs in our state, and also the process of upskilling those that are functioning in community health worker capacities. Just some tidbits about Alabama. I doubt anyone will be surprised that we are very poorly ranked in most metrics that involve healthcare, economics, education, lots of areas. And so some of those include, we're ranked 42nd in healthcare access, 35th in healthcare quality. We also have other several rankings that impact our social determinants of health for our state and our communities. 41st in business environment, 44th in economic opportunities, 47th in education, and 41st in internet access. So to say the least, we have a great deal of work that needs to be done across our state. And so looking at partnerships, I will not take any or little credit for this. This grant effort was a combined effort. I just happened to draw the short straw and was invited to present on behalf of our group. And so the collaborators that worked with me on putting this grant application together involved my social work colleague, Dr. Javier Boyes. He serves as the chair for social work here at Troy University. Dr. John Garner was the dean of our college and also helped in the effort. I represent the School of Nursing, and we also combined efforts with our Continuing Education and Outreach Department. They actually are the entity that houses our program that we'll talk about in just a few minutes. And they help with our registration, awarding of certificates, and just management of information. We realized that as an academic facility, we needed some more community partners. As a School of Nursing and Social Work, we have a good bit of rapport, but most of those are with healthcare systems. And so we know that building some more partners at the community level is going to be important, especially across the entire state. Our partner in this effort was the Wellness Coalition. They are a nonprofit located in Montgomery, Alabama, and they had a wealth of different partners to bring on board. And so they served as a collaborator with us. And then in terms of apprenticeships, the Alabama Office of Apprenticeships is the group that governs that process in our state. So we'll talk a little bit more about that in a few moments. So recruitment and retention, this was a big and important effort on the grant, and it's been a challenging process. One of the big things that we started off out with was, the branding, the message, how to spread the word, how to recruit, how to reach the communities that we definitely wanted to target. In Alabama, we have 67 counties. Here on the map, you can see those that are indicated in blue are the counties that we have been able to reach. We have had applicants and have actually entered our training program. So out of our 67 counties, we have been able to recruit trainees from 40 of them. And we're working very hard to touch those gray spots as well to make sure that we bring in trainees from those areas. We're still working on branding, creating our logo, having something solid, something that can really represent the grant effort. We are focusing on community visibility, being out at events, going on the road and visiting the different communities and being a part of that. Troy University, in terms of the state, has a good recognition. We are pretty well known across the state, but that doesn't mean anything about our community health worker program. And so we have really had to work hard to spread the word and the message about this training opportunity that we're offering. The other big piece has been the screening and selection of trainees. We have been very fortunate in our first rollout and messaging campaign that we put out initially upon awarding the grant, receiving an award of it. We had over about 800 applicants that came forward. And so we were not short of applicants, but the problem then that we faced was, how to make the best selection, how to pick the best applicants that are going to go back into the communities and do effective work. And so that really has been the challenge that we have struggled with so far in the groups that we have brought on board. Retention has also been an issue. That's something I'll cover in just a few moments in a different slide. But one of the other pieces that we are building towards as we're finishing our first funding year is looking at adding a success retention coach. We had some support people in the course already built, and we recognize that still just isn't doing the enough of the job. So we're working towards adding an additional person on our grant effort. All right, let's talk about the training and apprenticeship. So the way our program was structured is we built it over 12 weeks. It is a completely online asynchronous program. We knew that because of our geographical location in the state, we were going to be very limited in our ability to have an outreach in terms of bringing people in a face-to-face setting in a classroom. And so we went into this effort knowing that we wanted to produce an online program. It is exactly 10 weeks of modular asynchronous learning. Now, during those 10 weeks, there are times where the groups will get together, the instructors will collaborate with the students. There's a lot of group work and communication that happens. But there's not routine scheduled times that people have to log in and be together as a group. After they complete those 10 weeks of modular learning, then we move into an internship portion. Those last 2 weeks of the program, they're doing 60 hours in a field placement site. Again, our collaborator, the Wellness Coalition, works with each of the trainees to identify potential sites in their community. If they don't have one or they're just not familiar enough, then we can assist with providing some recommendations. And at the end of the 60 hours, they officially complete our training efforts. The stipends. And so the way we structured our stipends is we award $5,000 for beginning to end completion of the activity. We do that in 3 different installments. So upon about week 1, week 2, once we've vetted them, they have started completing work, they're engaged, then they get the first stipend award out. We give them $750 for that initial stipend. About midstream, 6 weeks into the program, then we award the second stipend. Again, that's another $750 that they will receive. And at the completion of the full 12 weeks and the internship aspect, then we award the final amount, which is $3,500. We realized that these funds, needed to kind of be spread out. We didn't want to just leave it hanging at the end, because we know a lot of our groups that are coming forward that want to participate, they have some financial concerns. We wanted to be able to support them, and that's really the essence of the grant, is providing support so that they can be successful in this effort. Creating the apprenticeship program has been an interesting job. It's been a lot of work. We as far as Troy University, really did not have any apprenticeship programs here affiliated with us. Alabama, I would say, is very early to the apprenticeship aspect, and so that was a fact-finding effort. And we worked very hard with the Alabama office. We had great support there from our regional officer. She really became a cheerleader. And I'm excited to say that at the end of the apprenticeship exploration, that we became the first community health worker apprenticeship program in the state of Alabama. So I was very excited that we were early onto that effort. We did have to meet the Department of Labor requirements as well as the Alabama requirements that were 144 hours of training was what was required. We also had to meet the floor wages that are required as part of the agreements between the employers and us as the educational facility. And we also had to make sure that we had very clear competencies and processes that these individuals completed throughout the apprenticeship. Our apprenticeship program, as far as the state, requires 1 year. I feel like it's probably fairly consistent with everyone. But that was a task to realize that we had to engage for a complete year after we finished the training aspect. Our requirements for entry into the program, just as some background, is just a high school diploma, a GED, or the equivalent. They do have to be a U.S. citizen or have a visa that allows them to be working in the United States, and then obviously a resident of the state of Alabama. And so looking at some of the successes and challenges that we faced, again, we were the first community health worker apprenticeship program in the state. I'm very excited about that. There were 2 other groups outside of Troy University that received the same grant funding through HRSA. And so we've talked with them, we've worked with them on different efforts, but very excited that we came to the line first on that. Reaching the communities, that again has been one of the challenges. The word is out there, but really reaching the communities, the individuals that want to give back, that want to help their health of their area has been the challenge. Some of the things that we've ran into in terms of the recruitment aspect that I mentioned earlier was we've had a lot of interest. I feel like probably just from the training aspect, also from the stipend piece. And so trying to find the best fit for the program to make sure that someone's going to come in with the right interest and want to go back and make a difference in the community has been one of the greatest challenges. Again, that we still have the strong community interest though. Development of the training program. I'm very excited that within a very small window, we were able to pull the training program together. We contracted with several faculty within our university to provide the expertise in those content areas. And we were able to pull that off and get it together in a very short time period. And we've made a good bit of progress over this first year. To date, we have 5 cohorts that will have gone through by the time the first fiscal year ends. We've completed 2 of our cohorts. We are currently finishing up our last 3 of those. And retention, again, has been a pretty big concern. Just to give you some numbers of an idea, our first cohort, we started with 32 that came and were accepted into the program. Out of that first cohort, we completed 17. Our second cohort started with 34, and that cohort only completed with 9. And so retention has been an incredible thing that we're facing. We're seeing trainees that come in that drop early on because they didn't realize the investment at the time after week 1 or week 2. And then we have those that continue through the program, maybe midway, but drop out about 3/4 of the way before they get to the internship experience. And then we have a small pocket of people that make it all the way through the training piece, but then get to the internship aspect. And for whatever reason, they're just not successful in being able to complete the internship. So this is something we've definitely recognized. This is something we're working as far as our recruitment strategies, our retention strategies. This is a big piece of adding a success and retention coach that we're hoping is going to make a huge difference. We have embedded in the program right now what we call academic success agents, resources, and they're there to provide the tech support if it's a struggle with how to work within our learning management system or how to upload some type of activity. But I think we need more of a cheerleader, somebody that can really talk to people on a one-to-one basis, where these individuals are only more on the tech aspect. Our challenges involves really, the situation within the state. There is no formal recognition of community healthcare workers in Alabama. There is no certification process. There's no reimbursement process in our state. We also have a lot of mixed terminology pieces. We have people that function in a community health worker capacity, but rather they're called something else. It may be a care navigator. It may be a resource, a liaison. But for whatever reason, the terminology is very different and very diverse across the state. And so trying to build a support structure is something that we need in the state, and the ability to be able to show the return on investment of the work that community health workers can do. We do have one of the grantees in our state that's working on a coalition to build a voice for the state of Alabama. So I'm hoping that over the next 2 years that effort's really going to grow and support community healthcare workers. The other aspect is the apprenticeship wages. Because the apprenticeship requires a certain floor wage and then progression among that pathway as they finish the program. A lot of our healthcare agencies just are struggling to figure out how to integrate community health workers, especially when the return on investment, the billing aspect of that is just not a direct return. So we're having to do a lot of education to demonstrate how community healthcare workers can really impact whether it be for a healthcare facility, return of chronic diagnosis, readmission rates, or whether it's physician private practices, where it's education and teaching. It's a struggle. Getting apprenticeship employers to sign on has been one of our greatest challenges. In fact, to date, we only have about 2 organizations that are signed on. We have a couple that are in the pipeline that we're working with. But that has really been one of the greatest challenges, is getting apprenticeship opportunities in our state. And so hopefully that was beneficial. I appreciate the time. And so I will end my presentation.
Excellent. Thank you so much, Dr. Braidforehand. So we will now turn it over to our final group of panelists, which is Dr. Cody Mullen, as well as Margarita Hart from Purdue University in Illinois.
So good afternoon.
Apologies, Indiana.
Yes. Good afternoon, everyone, or good morning, depending where you are in the country. Now that I shared my screen, I've lost where Margarita was on my screen. So I'm trying to find.
I'm right here.
There you are. Perfect. Thank you. So good afternoon, everyone. My name is Cody Mullen. I'm a clinical associate professor at Purdue University in our Department of Public Health. And I get to serve as the PDPI for our community health worker training program. And then I'll let Margarita introduce herself.
Yeah, I'm Margarita Hart. I'm the director for Indiana Community Health Workers Association here in the state.
So as you've seen from a lot, so this is in partnership between Purdue University and NACHW. And we do have our disclaimer. We are not representatives of HRSA, nor do any of the remarks that we have should be viewed as official statements nor endorsements from the federal government. And we're grateful for their funding that they provide for us to be able to build upon this project. So we all have similar slides of areas of partnership, but I love to start that. As I'm on here and Margarita's on here, we're just two of a lot of individuals who've been touching this project and expanding that. We have partnerships throughout the state of Indiana to support the expansion of this. We have cross-university partnerships as well as nonprofits. We're currently partnering with Purdue Extension. So Purdue is the land-grant institution of our state. So that means we have an extension office in all 92 counties of our state. And we'll talk about that in a minute of the uniqueness that allows us to be able to have partners who are within our institution in every county, rural or urban, to help with troubleshooting for different issues and concerns. Our partnership with NACHW, which I'll turn over to Margarita here in a minute to present on. We also partnered with the Indiana University School of Medicine and some of their We Care program that they've developed specifically for infant and maternal health. SACOA, which is a large service provider in our state capital. The YMCA of Indianapolis, IU Health, which is the large health system of our state, and Damien Center, which is a healthcare center in our state capital. Each one of these individuals were identified during the production of our grant. Initially, this is an initial discussion between Purdue and NACHW, but then others came on, and they all had unique areas where they could identify areas where community health workers would support the mission that they are trying to achieve. I'd love to hand it over to Margarita also to discuss our partnership with NACHW.
Yeah, thank you, Cody. Our role is to provide CHWs with a tapestry of community to help them grow in their professional citizenship. We help create a healthy community, so this includes CHWs that are in healthcare, that are in social services, agencies, and unconventional sectors. We approve the training programs for the state of Indiana, and we worked very closely with training providers. We have 2,650 members in our association, and 750 of those are CHWs that have been certified. We touch over 40,000 individuals through our social media presence, and so we work as an association. We're really their community. We're a community for the community health workers, and we provide social connectivity for them to continue to develop their CHW profession. I have.
Wonderful. So in our partnership with NACHW, we meet monthly for discussions and sharing of our struggles, and then also learning around the state of where can we be a resource, where can this funding be a resource for our state. So our recruitment of participants, if you notice that this list of partners is very similar to the list of partners we had on the prior slide, and that was specific, right? So anyone that we partner with, we want to help us with the recruitment. We recognize, and the goal of this funding from HRSA is really to work with individuals who may not traditionally be part of the community health worker workforce, or be able to identify that. So like I said, Purdue Extension is a unique partnership. So they're in all 92 counties. So we were able to present to all the extension educators across our state who are embedded with multiple community organizations that one individual or even one team could never be embedded with statewide. NACHW has shared a lot of the information about our grant program through their social media. We'll talk in one of our challenges. We actually had a request they not share our program anymore because the need and the demand for the program was much greater than what our team could partner with. But we also find it interesting that as these sentees say, oh, I have staff who want to participate in this, or I have staff that I encourage to participate in this, or I'm looking to hire someone in this profession, can you help identify that person? That on-the-job training is immediately there, right? Their employers incentivizing them to come complete the training, or they're offered employment as soon as they're done with the training. So that on-the-job training is right there. We have our flyer here that we've shared this. We've translated this into Spanish as well, that we share widely and broadly. And then using a QR code, have a Qualtrics survey where our participants are able to self-identify of their interest moving forward. So we look at our training in 3 unique areas that we develop with that. So there's the initial certification, which NACHW is the certifying body for all training across the state of Indiana. So currently we're doing that in partnership with Health Visions. We are currently looking at further expansion of additional training sites as our demand has gotten so great. Also, as part of the grant funding, we are supposed to offer an advanced training, which a lot of my fellow panelists have shared today. And in that advanced training, we're looking at various areas that maybe the initial certification doesn't have as much time or depth to, or it's a newer area like vaccine delivery and hesitancy, emergency response, sexual and reproductive health, health equity. We crafted this in a way that there's the core training in this advanced training that all participants must complete, but then we have additional modules depending on where they're currently working or where they would like to work in the future, where they're able to go in and get that training. We then have a secondarily Canvas site where all the resources that they've had, they will have in perpetuity, or as long as the grant will allow us to keep it. So they saw resources that they wish they could use to utilize when they're partnering with someone in their community, they can quickly and easily go out and access that. As other programs, our apprenticeship program is in development, but that has been delayed with state approval. There has been a lot of apprenticeship movement in our state for that moving forward. So retention of participants, this has been a large area associated with that. So one is in support and curriculum delivery. As several other of the panelists were with universities, so I also run our online MPH and MHA programs as the other part of my job, or the other hat I wear, depending on the day that I'm working. And the nice thing about this is some of those skills that we utilize with our graduate students are the same skills that we're utilizing with our community health worker trainees, right? Of how do I interact with the learning management system, or what are the technology barriers, but then also what are those work-life balance or incorporating in study time when they're not used to traditionally being in the classroom. I know anytime I have to do a training, right, it's rethinking, like, yes, I've done this before, but it's readjusting to that, especially when they're doing that over a multi-month period of time. We have frequent check-ins by our project staff to ensure both comfort with the material and understanding of the requirements. As one of the previous panelists mentioned, this is a federally funded program. There are a lot of reporting requirements. So we want to make sure that everyone is comfortable with what is the requirements associated with that. Then lastly, what the grant can really help us provide is stipend for financial support. We recognize that by participating in this curriculum, there may be issues around childcare, or if they're currently working an hourly position, that missed shift is lost income that can have direct effects to the resources available to that home to support themselves. Technology, having a computer, using Zoom for the first time, uploading a PDF, skills that some people may not think is that hard, but we recognize that getting that out there is needed, and that's where extension also helps. And then lastly, healthcare access. So if we look at our successes and weaknesses, I would like to highlight that our successes and our challenges are the same at the top of our list. Again, that was on purpose. Our wait list is exceeding expectations. Our proposal was to have 42 people trained per calendar year in our initial certification. Our wait list is greater than all 3 years of the grant, and growing. We have about 8 new people get added to our wait list daily. So that is creating both a success, right? Yay, the community health worker, we're recruiting diverse individuals into the program, but it's also right now our next available training for you is in February of 2024. Can you wait? Which for some, that's not possible. Other successes, understanding amongst partners the values of CHWs within their team, that unique partnership that a CHW that I know I'm preaching to the choir as part of this panel, but helping us have that conversation, and then the proof is in the pudding once they're out there. Sharing of diverse topics beyond the initial certification is a success. Hearing those ahas of, oh, I really knew how to do this, but this has helped me go even further in the advanced training to be able to support that. And then financial support to those who otherwise could not participate, right? That financial barrier has been removed. Challenges, I've mentioned the wait list, access to initial certification with increased interest in CHWs, right? Just the capacity of our training partners to support that. Then lastly, the stipend that is received that is taxable income. And as being taxable income, that does affect their overall income, which then does lead into, if you are receiving federal or state supports that are income eligible driven, that may cause them no longer to be eligible. So we've had to do a lot of counseling with individuals about, yes, there's a stipend, but what would this mean overall? Because yes, this is a stipend, but if there's not employment right away, how do we balance that moving forward? When we're looking at the broader picture of the potential benefits. I know Margarita, I think, had to get off, but oh no, I see her. Anything else you'd like to share, Margarita?
No, it's been really surprising how this has impacted our workforce, because a lot of the CHWs that normally would not have been CHWs, but have been doing CHW work, that are in very non-traditional CHW roles, have stepped up to go ahead and get certified and go through this process. So it's been a huge blessing to our state.
So I have both of Margarita and I's contact information, or if you know how to get rid of reach one of us, the other one can connect you to the opposite side. So I'll turn it back over to Ben for the next portion of our webinar this afternoon or morning.
Well, excellent. Thank you again to all the panelists for providing all of the information about your programs. And I also want to say that we will be working to try to get everybody copies of the slides and kind of contact information for each of the panelists today. I want to say I've been so impressed by how active the chat has been over this first hour. There have been a lot of great questions being posted, and I also appreciate that panelists, participants, and NACHW staff have all been trying to jump in to answer questions in places throughout. We're running a little bit behind on schedule here, but I would like to try to save 8-10 minutes here for questions. So I'm going to ask people to try to come off mute now and pose questions for the panelists to consider or answer. And you can do that raising your hand. So let's see if we have any folks that would like to pose question to the panelists. And we have a couple people already here right now. Let's maybe start with Yanel Powell first.
Thank you. I don't have a question. I just wanted to commend all the presenters today. Great job. We're struggling in Delaware, so a lot of this probably can help us with getting our stuff up and going. So great job, everyone. And thanks for sharing.
Absolutely. Yeah, I think the next person I had seen, I think was it Tanisha Dungy?
Yes, excuse me. Caught me in the middle of reading.
No worries.
Question, what is the difference between a certified and a certificate CHW?
Any of the panelists be willing to try to take that question?
A certified community health worker has taken a state test or the national test.
Okay, yep, so that in some cases that's the case.
Can I help here? So certificate community health workers receive after the training. So all training certificates are not certification. Certification is like a license in the profession, and it is received from the state health department.
Okay, so we will go through our state health department if we have been through the class.
Yes, you need to
and we want to be
certificate and fill out the application and go through all the regulations of your state.
Thank you.
Yeah, and as several people have been pointing out in the chat here, it can really vary kind of based on the state that you're located in. So I think connecting with your local CHW association or your state health department to maybe provide more clarification based on where you're sitting at. Just kind of going through the list here of other folks that have hands up. I think I had seen Rick Rabin had raised his kind of early on in the order. So how about you go here? And if it might be helpful too, if there's a specific panelist that you'd like to direct questions towards too, that might be helpful. So.
Okay. Well, my question really goes to all of the panelists. Given that most of the clients of community health workers are low income, and if they work, they have not very rewarding jobs, to put it least. Do you offer training in occupational health and safety so that community health workers can help your clients? And if not, currently, is that something you would consider doing, offering that training?
Would one of the panelists like to take that?
I can throw in a piece from Troy's end. So we build that component into the on-the-job training during the internship. And so that is part of onboarding them to whatever site that a community health worker may be functioning in for their internship. And so a lot of that is the OSHA, the HIPAA, those kinds of things that would impact the work that they do.
And this is Ponegis. That's why our program is meant to be adaptable. You know, plenty of community health workers have gotten back to us saying, you know, our job's asking us of this and that, so we'll devise a curriculum to help adapt to that. For instance, one of that has come up recently is training for smoking cessation. So we have a 6-hour tobacco treatment course for them to take. So we try to adapt to what their needs are so they can stay hireable and more than anything, have their opportunity to transcend where they're at. So yes, I think that's going to be important moving forward.
How about Bonnie next? I'm seeing Bonnie with a hand up.
Thanks. Good afternoon, everyone. Oh. I'm sorry, did you say Bonnie or Bonnie? I see our names are similar.
Oh, apologies about that. I had said Bonnie, but okay. I can maybe we start with Bonnie and we can go to you next, Bonnie.
Sure.
Thanks. I'm from Arkansas and we have the same grant. And one of my questions to the panelists is, are you enrolling non-employed people into CHW training programs and training them and then hoping that they find employment?
So this is Cody at Purdue. We've trained probably 20% are individuals who are currently unemployed or looking at making a career shift. And then several of our partners, we're kind of created a job board. I say that very, very loosely of, okay, you're in this region. Here's a couple who are looking for individuals once the certification is complete.
Thank you.
For Troy University, we've actually had to do some screening. That's one of the things that we're working towards when we screen candidates, because we've noticed that some of the individuals that have come forward and participated in our early cohorts had very secure jobs, had been there for many, many years, and did not seem that they were going to make a move or a jump. So we're actually favoring those that may not have a very consistent employment history for our program.
Let's go next to Bonnie.
Thank you. I was wondering, I work here in Minnesota for the Minnesota Community Health Worker Alliance, and I'm actually the HRSA grant Field Experience Apprenticeship Coordinator. And so this, first of all, this webinar is very helpful for me to just listen in on what kinds of challenges and successes you all are having with the apprenticeship program. And I'm wondering if any of the schools or any of the people who have spoke here today have had any experience or anything to share as far as keeping the apprenticeship on or keeping the apprentice on at your various organizations after that 1 year or whatever the apprenticeship agreement is.
Any of the panelists want to jump in for that one?
I think it's a little bit too soon because they have to be there for a year. And actually, we actually had trouble getting the apprenticeship program up because of all the various administrative processes that were a little complicated. So we are just now beginning, but I believe that not one of us would be able to answer that. We are optimistic, how about that? But we don't know. I mean, the challenge is, can we do it, right?
Right. And I'm also seeing Laura Thibodeau here.
Hi, yes, I just had a quick question. My state, which is Vermont, does not recognize community health workers. I've done the training through school and everything for community health worker, but having a hard time finding employment because they don't recognize the schooling, I guess, or the job title. So I don't know what recommendations would you possibly have to be able to do community health workers versus being rogue, so to speak, just doing it myself?
Great question. Also might be a great one for the breakout rooms to consider more, because I do think it goes a little bit beyond the scope of maybe the HRSA grant to kind of larger recognition issues. But any of the panelists want to jump in on that kind of before we get to breakouts?
I'll jump on that because, you know, we've thought about this as well. Like, you know, community health worker, this term is still relatively new. And at the same time, it may not be understood of how to best, you know, bring in such talent. Where, you know, one of the thoughts that we've had here in Baltimore is, can we use a certificate to be leveraged more as a skill for other positions as well, right? What if a teacher at a rural school did the CHW training in order to leverage those skills for where she or he is already at? So one of the ways is potentially, could we use as to create its own job, or can it help other individuals really stand out with more leadership capabilities in a position where, you know, access to health and healthcare is really hard? So we saw a lot of that during the pandemic, where we were repurposing teachers constantly. And so we're in the talks of potentially seeing if the training could be utilized in other ways. So I think, and we can talk about more in the break room, but I do think it's an important thing to recognize what can you do with such great training to help people get meaningful employment for them in the community.
I would like to jump in. I'm Corzetta Jones, and I'm from Huntsville, Alabama. I'm going through the training as we speak. What I found is here in Alabama, we have a mental health hospital, and they work with children. And through the peer counseling or the peer support, they have created positions for CHWs because they need peer support, parent support. Then they need this title called a care coordinator. Now, this means that this doesn't mean you have to have a social work degree, but that CHW now, once you go through the certification or the certificate program, it qualifies you to be in that position.
Thank you so much for providing that background. That's great, Corzetta. Let's go to Valerie Jackson.
Thank you, Ben. This question is open to anyone, but Wade specifically, since you presented last. I'm just looking for if you could provide some clarification around the apprenticeship itself. So apart from the training, the apprenticeship, which requires on-the-job training, right? So that means that folks that you have in order to participate in the apprenticeship need to be employed? Yeah, okay. And so have you been able to enroll anyone yet on the job training apprenticeship activities?
Yeah. So we have, oh, excuse my telephone. We have enrolled about 2 individuals that have committed to, knowing that it's a year-long engagement and that they're invested in wanting to follow through that process. They are employees of the site that is serving as the apprentice host.
Yep.
So they are employed, they are paid a wage, and that as they meet certain competencies through that process, then that wage is increased. And so the hopes are truly that at the end of that apprenticeship, and once that ends at that year level, they've mastered all of those competencies that's required, then they receive a Department of Labor certificate that they have participated in an apprenticeship, and we are hoping they're going to stay on with that employer and maintain a relationship with them for a long time.
Yeah, thank you. That's what we're trying to, here we are in Maine, we sound like the same type of program, and that staying on, they then become journey workers or trainers for the folks coming behind them. And I was really specifically interested if you had enrolled learning more about how you got those partners. I know you mentioned you have 2 employers, so, and I can connect with you offline.
Sure, yeah, feel free to.
And with me, please. MCD.
Yes.
I'm Vanda, please.
We will, Vanda, we have you, we get you.
Yes, please email. One thing that we have found as a benefit to the apprenticeship piece is we have found that there are certain sites that hire individuals that would fall within the realm of a community health worker. They may not be called the community health worker, but they function in a very similar capacity, and they need an onboarding or a training process so they don't have to train on the job. And so we're trying to partner with a couple of groups in that capacity where we are the trainers for their new employees, and then they will follow through in an apprenticeship type fashion and work for that site. So that seems to be a niche that we're able to fill with a couple of sites that we're working with. But yes, feel free to email me. I'll be glad to engage with you guys after this.
Thank you.
So at this point,
I've been texting with Dan.
You know what? I think we have Sarah. You are.
I thought it's today.
You know what, Sarah? I think you need to go on mute. I'm not sure if. Yes, perfect. Okay. Well, I would love to keep going here for probably half an hour more on questions, but I do think at this point we should probably transition into our final activity on the day, which will be the breakout session. So encourage those of you that still have questions to post them in the chat, and also potentially try to post them to any of the specific panelists, and we will be trying to provide contact information to also make connections there after the webinar today. But the breakout sessions will be an opportunity for participants to engage in conversations about kind of larger picture considerations around workforce development. This could be efforts underway in your state to fully recognize CHWs as professionals or build policies or supporting infrastructure for the field. So I will do a quick kind of share screen here in terms of some of the questions that we'd be looking to, bear with me for just a second here, folks. So just a few of the questions that we'd be looking to cover as a group. Bear with me for a second. Again, thinking about how are you considering larger workforce decisions like scope of work, definitions, financing? How are you involved with larger efforts in your state around building infrastructure or policies? And what efforts are underway in your state to ensure that CHWs are fully recognized as professionals? And in terms of breakout sessions, we will have a number of the panelists as well as members of the Workforce Development Committee in each rooms to help facilitate discussions and take notes. And then we will come back if time allows at the end and kind of do a brief reporting back. So At this point, Peter, are we ready to jump into breakout rooms?
Yes, they are now open. And for 15 minutes, I'll set the timer.
Could you move it down to 10 minutes? Is that possible?
Sure, no problem.
Perfect. Great. All right. Well, people will now have a chance to pop into the breakout rooms, and we will begin those discussions.
I'm not seeing the link for the to go to the breakout groups. Can you post it again for me, please? Thank you.
Me neither.
Hi, all. So all you need to do is there should be the menu with the 3 dots titled More on your Zoom. And
so it does sound like there's a few. Yeah, go for it, Peter.
Yeah, and just click on that, and then you are able to select the breakout room you want to join. You can go to the breakout rooms option on that menu. Nope. Any room is good, whichever you prefer.
I don't see any choices. I clicked on 3 dots, but no choices to join the breakout room.
If you go down in the bottom where they have the mute, the start video, you should see the prompt that says breakout room, and then you should select the room.
No, still no.
Well, welcome back to the full group. For those of you that are making your way back in, we don't have a ton of time left, but we will try to do a quick kind of reporting out from themes that were coming up as part of our breakouts. So in the interest of time, I am going to call on a couple individuals that were assigned to do some reporting out. So Kimberly Haley-Fair, would you be willing to maybe get us started on just a few observations about what was coming up in your breakout?
Yes, thank you, Ben. So in our group, we primarily talked about CHW salaries and apprenticeships. So making sure that we're vocal about the apprenticeship, what's covered, and making sure that we're contributing to more knowledge about CHWs in the space and the value that they have. And that may increase the number of places that are giving us placements for apprenticeships and hiring. And just going along with that, we're advocating for legislation, and we heard about people applying for certificate programs in their states. So we are understanding the importance of CHWs, but we want to make sure we pass that along to employers and other advocates, and making sure that we can get CHWs in a place that a lot more people are recognizing their value and their contributions to the space.
Excellent. Great observations there, and great discussion. Let's move to the second breakout group, and I believe it was Tasha Whitaker that was in that group that was helping to report out.
Yes, so in this group, we talked a lot about the definition of a CHW and the scope. And so some of the things that were brought to the conversation was how to define what that role is. For example, with some community health workers, they are seen as more of a provider. And for some CHWs, they're seen as more boots on the ground. And so having that definition and that distinction is very important. We also talked about the scope and staying flexible. And so one of the organizations talked about how they're more health promotion, but they had to maneuver and really move toward more of what the social needs were for their community that they were serving. So it's important to remember to be flexible, and that, you know, how you're serving your community, it might shift based on what the community needs at that time. And then we talked about the definition of how to refer to the patients being served. So do you refer to them as clients or patients? And so the distinction between that basically came down to maybe what the CHWs refer to them in the community. So they may refer to them as clients because they're clinical, or they may just refer to them as individuals because they're not as clinical. So there was a lot of conversation about the distinction between definition of CHWs and how to be flexible in how you're disseminating your program out to the community.
Excellent. Thanks so much for that report back. Awesome as well. Let's go to Lily Lee next, who I believe was in group 3.
Yes, group 3 began conversations to talk, discussing how different states have different policies that's now really pushing to include CHWs across all different sectors, including healthcare programs. But there's, still much need and gap in really figuring out how to do the billing, and whether CHWs can be also integrated in, how they can leverage the grants and other programs that would sustain the workforce. We also discussed about different infrastructures needed in other states, especially in the areas of mental health. Elderly populations, Spanish-speaking communities, and CBOs who have CHWs trained, and now they're trying to start programs that would be sustainable and well-funded. So that's, we also, got into certification, and one of the members discussed how a success story about even through COVID, they were able to go from a, early certification process to now having a certification commission and having CHW voices in their state. And that was the state of Arkansas. So I'll stop there to give others an opportunity to share.
Excellent. Thank you so much. I was assigned to group 4, so I'll do my best to kind of encapsulate some of the comments here. I think something we were discussing is there was really some significant differences for the folks on the call in terms of where their states were at, whether or not they had developed a certification process or they were not at that stage. I was also raised during the group that certification is nuanced and not necessarily kind of the end all or be all, and that different states have different models in terms of some being able to actually have Medicaid reimbursement even without a certification system. So that was a comment that was offered up there. I think there was also a lot of discussion around trying to develop CHW associations and networks in states that can be the collective voice for CHWs. Again, there were some differences there in terms of some states being further along in that process than others. Very interesting to hear about some recent work going on in West Virginia to create a workforce consortium that would educate policymakers and would also help to advance the voice of CHWs in the state. And right as we were cutting off, there was also a really interesting comment around kind of different perspectives between a supervisor and an employer and a CHW, and those are not synonymous. They're not kind of equal to one another, and the importance of having those different perspectives balanced. So yeah, I will turn it over next to group 5. And I believe we had Tara who is going to be doing the report out there.
Yeah, absolutely. In our group, we began to talk about scope of work first, specifically lack of foundational knowledge and beginning where that foundation start for CHWs. So defining that scope of work is becoming difficult for all regions. They just kind of do what they want on their own and do what they think works. It's led to confusion, but also some leaders are taking it upon themselves to create databases of what can be more of a standard foundation for what's working within these scopes of practices for CHWs. People were questioning how we can continue to support clients and patients without moving to work outside of their scope of practice. How do we create and define that scope with so many various job titles? Some suggested that getting back to the core skills and competencies will help in defining and also following these core skills and competencies all the way through our standards of training. Also, people mentioned advocating for CHWs with providers. Many providers misunderstand the role in the scope of practice for CHWs, as well as valuing CHW experiences since they know and represent their communities and their positions best.
Excellent. Yeah. Well, thank you everybody for taking part in the breakout groups and for the folks that were reporting back. We are at 3 o'clock now, so I do think we will need to wrap up just out of respect to people's time. What I'll say is that you will be receiving a SurveyMonkey link after this, and we would love your feedback to know how we can improve this session and kind of what is the interest in terms of trying to continue to convene folks that might be involved in CHW training and apprenticeship programs around the country. We have questions in there around topics for future sessions or what future formats could look like. So we would certainly appreciate your feedback in that way. But otherwise, again, I want to thank the panelists, the members of the Workforce Development Committee, and participants for joining today and for being so active in your participation. So take care, and we will be in touch. I hope to see you all soon.